Hi, my name is Dr. Salil Kandwala, and I'm the Medical Director at Advanced Urogynecology of Michigan. Today, I'm going to introduce our practice to you and welcome you to our practice. And in that, let me just start by telling you a little bit of my background. So, I started as an obstetrician and gynecologist, but then I did my subspecialty in this field, which was called urogynecology and is now called this big long name female pelvic medicine and reconstructive surgery, or FPMRS. So I'll tell you about what we do and how is our practice philosophy, and I'll introduce you to some of our colleagues who work with me. So this female pelvic medicine and reconstructive surgery, that big long name that I said, or FPMRS, is our subspecialty. And it basically addresses all the organs of the female pelvic floor. So if you look at this, this is a woman standing up. This is the head end, this is the foot end, this is the front, and this is the back. You have the bladder in the front, which stores the urine that comes from the kidneys. The urethra is this tube right here that brings the urine to the outside. The vagina is behind that. On top of that is the uterus, and behind that is the rectum. So that's the classic orientation of the female pelvic organs. This is our team at AUGM that you'll be seeing. We have a different philosophy than what you may have seen in the past with other practices. So the question is always, should the practice be a physician-dictated practice or should it be a patient-directed practice? And that's a toss-up, what we want versus what the patient wants. And that may not be in sync, but what I wanted to do maybe pulls apart from what she really desires. And as a doctor, we need to merge this. This has to be one common philosophy, more paying attention to what the patient wants rather than what we want her to do. Remember this movie, What Women Want? That's more appropriate than this movie. And it's not about what physicians want, it's what the patient wants. So it's all about what women want. And that is our emphasis because we only see women in our practice. So why is our practice a patient-controlled practice rather than a physician-driven practice? Well, did you know that 65 to 75% of women with bothersome urine leakage do not return to their specialist doctor, not their primary care doctor, but a specialist doctor, someone like me, after one visit, and they continue to suffer in silence? Now that doesn't make any sense, does it? A large chunk who are bothered by urine leakage do not come back to their specialist after one visit. And then you wonder why? Why does that happen? And there are many reasons, but some of them are they did not understand why she was prescribed the treatment. Proposed treatment that what we tell her to do is in conflicts with what she has heard from family and friends or from TV. If we hear about a particular surgery and she has heard all negative things about it, she's not going to accept that. Information on the media is scary and is especially when it comes to mesh and sling management or whether it is hysterectomy for fibroids. And they may have had a treatment which did not work. And they said, well, I went to this doctor, he put me on the treatment, he's a specialist, it still did not work. Or a treatment could have had more side effects than effects or benefits. And it may be effective, but was very costly and, cannot afford it. So you say, I can't take it. It's exorbitant. The symptoms improved, but it did not meet the patient's expectations. And she just could not follow up. So those are the different reasons. So what we found is that when we see our patients, for us, communication is the most important thing. Communicating with the patient and the patient communicating back to us. That's the cornerstone for a successful outcome in healthcare. Educated patient is our ally. Ultimately, it is the patient who should decide what is best for her. It is the patient who knows best how much that particular problem is bothering her. We can tell her all possible treatments, but it is ultimately her choice to decide whether she wants it or not. Physician's goal, that means my goal, should be to provide you with the correct information in a language that she can understand. Not use words that are complicated and Latin words that we use in medicine, but simple words. Not urine incontinence, but urinary leakage. Physicians should put the risk benefits in perspective so that the patient can assess its magnitude, and we'll talk about that in a few seconds. And physicians should then guide the patient along the treatment course. Not just the first time and say, all right, we'll see you back, and never follow them. The physician and the medical team should make sure that the patient actually continues the treatment plan, and that is what we do in our practice. And if there are any changes to the patient's health, treatment outcome, or even financial status, then the team should be able to adjust and modify. Sometimes some medications are affordable, but now the insurance changes, and now those medications are extremely expensive. And if we do not alter things, then the patient may not be able to afford taking the medication and she won't take it. So we need to adjust too. So the goal should be to be able to provide optimal and customized care. Nothing is in vacuum. It's all theory. In practice, things are very different. Bottom line, in our practice, our philosophy is you, the patient, is in charge. You call the shots. You decide what happens with your health. We are here to guide you at your behest, milady, just like what this particular slide says. So we don't tower over you. You are in charge and we are here to help you. Not like this, towering over the patient and say, my little man, how are you doing this morning? That should not how we address things here. In our practice, we believe in this decision-making models, and we have several decision-making models, and this is one of them, which is the risk benefits. So whenever a patient comes in, we want to offer them the benefits, but also explain to them what potentially risks could be happening with that particular treatment. So the goal is to explain to the patient, as far as the pelvic floor conditions go, what is your normal anatomy? What is the abnormal anatomy that is happening now? Why did it happen? What are the typical symptoms and patient's history? And what are our findings? What tests would we recommend? And make sure that you understand the complete diagnosis and how did we come to this particular diagnosis. And then once we know the diagnosis correctly based upon the above findings, we can then go over the different treatment options that are available to you. Provide the facts. That's what we do. We provide you the facts in an evidence-based manner. This is not just, it's not a hunch that, oh, I think it'll get better. Our facts are based upon results, outcomes that we track over time. We make sure that the patient, that is you, understand what is meant by success of treatment. Now, this is very important. So what is really success? Now that varies. Is it absolute cure? That means it's all done, all gone, or is it an improvement? See, sometimes people would say, oh, it has an 85% success. But then what we would tell you is we will explain to you what that means. So when it comes to overactive bladder correction, 85% means 85 out of 100 women will notice at least 50% improvement in their leakage complaints. So for example, if I was leaking 8 times in a day and now I'm leaking 3 times, then I'm a success because I'm leaking less than 50%. 4 would be 50%. Since I was leaking 8 times, now I'm leaking 3 times. So I am considered a success and I would fall into this category. But what if my expectations were different? I wanted never to leak, then it would not match. So once we define this, so what we will do to you is we will tell you exactly what we mean by success. It's different from cure, and sometimes we cannot get to absolute cure. You may be significantly improved but not cured. So what we will do is we will match this, your expectations with what is considered as realistic expectations based upon true evidence in science. Now, this is also important. Fine, now you know the risk benefits, but what about the cost of treatment? What about the recovery as opposed to benefits? So Yes, it may be a highly successful procedure, but what if it involved a huge operation under anesthesia, which went on for 3 to 4 hours, and you were in the hospital for 3 to 4 days and recovering for like 6 weeks? You'll say, forget it, man. I'll just deal with this. I don't want to go through that. That would be the recovery. On the other hand, if I told you that, hey, I could do this right in the office and takes about half an hour and it's done, you'll say, sign me up. Cost also is important. It's sometimes now, especially with the healthcare costs escalating, most of us have a co-insurance or deductible, and you may say, I can't afford it, if I have to get this done. And that's important for us to adjust. Yes, the benefits are fantastic, but cost may be too much. And then also it's the degree of bother is also important with benefits. So, oh yeah, this is works great. It has almost 99% success. Let's say in our hands, the sling procedure for stress incontinence has 98% success. But what if someone just leaked very occasionally when she had a bad cough and she hardly coughs? Well, then she really doesn't need to go undergo that because she's not that bothered. On the other hand, she may be leaking occasionally, but she leaks when she plays golf and she really cares for her game and it bothers her game. Then yes, it's a bother to her. So even it may not be happening every day, but it bothers her when she really wants to enjoy the game, then yes, it should be taken care of. So that's what we take into perspective too. And don't forget, this is a very important slide. Treatment versus non-treatment. Just because you are delaying treatment or not having treatment or procrastinating does not mean that that's a good thing. Especially when it comes to patients with prolapse, when bulges are coming out of the vagina, the vaginal bulge, the bladder may not be emptying and it could damage the bladder or it could damage the kidneys or it can cause ulcerations of the vagina. Or even the fact that one is leaking, that could cause irritation of the vaginal opening and ulcerations of the vaginal opening. Or the mere fact that you're wearing a pad, that could also cause some vaginal irritations. So remember, the fact that you're not going through the treatment as we recommend, that does not mean that not doing anything is good. It may be actually worse than getting it taken care of. And it happens in most cases, and that is why you should not delay getting things taken care of. The other thing I like to say is putting things in perspective. Now, this is very, very important. Sometimes we tell patients, well, the risk of this procedure, for example, let's say we do the Botox procedure for overactive bladder. And we typically quote that the difficulty emptying your bladder initially after this procedure is about 3%. Now, when you put things in perspective, you could say that, listen, 3%, then you say, oh, wow, that's 3%. But then on the flip side, you have a 97 out of 100 chance that you will not need to catheterize yourself. And that's also important. Or with surgical complications, when patients ask me, what is the risk of a complication? And sometimes it's less than 1%. But they don't understand exactly what does that really mean until you put things in perspective. In other words, I very often tell my patients, the chance that you took on the road to come to see me, whether it's a good day or worse if it's a snowy day, is maybe about 10 to 100 times worse or more of a risk than what you would undergo with the procedure. So then they say, oh, well, now I understand a little better. So it's really important for us as doctors not to speak in vacuum, not just throw numbers out, but put it in reference, put it what it means to her from a day-to-day lifestyle. Finally, once you look at all that, then we come to the main crux. You've understood all those things I've talked before, and then what are your beliefs and desires? Now that's really, really very important. So a patient I just saw yesterday who told me that, yes, I want to get this taken care of, but I don't have any vacation time right now. So right now, her desire is to wait a little longer, gather some vacation time, and then she absolutely wants it to be done. Or another patient who I saw recently, her husband fell ill, got a stroke, and she had to take care of him, and she had to put herself on the back burner. And now she's back and said, I'm sorry, I didn't show up for the last several months, and because my husband was more important and he was not doing well. So really, we take that into account, and that is what we always ask our patients: why are you not getting the treatment done? So we will follow you until we are convinced that you are making the right decision for yourself. And that's how we guide you along the process. So yes, the disease state is there, which is the red light. We talk about the different management options, but ultimately the green light is you give that. It's up to you. And once you've understood this information and you've understood the risks, the benefits, and everything that's associated with what we can do for you and your options, then you will make the call based upon what you want at that moment in time. And we are here to guide you along. So now, having said that, let's just go over some of the things that we address at our office, and that's called the pelvic floor disorders. Remember I showed you the slide of the normal anatomy, again the bladder, the urethra, vagina, the uterus, and the rectum at the back. So from the bladder leakage, we take care of this condition called coughing, laughing, any strenuous activity, and that's called stress urinary incontinence. So that's when the urethra tends to fall back because the tissues have weakened, resulting in urine leakage. Or the gotta go leakage, called the urgency leakage, where you have an intense urge to go to the bathroom, and before you can make it, it's just coming out. The other condition is bladder discomfort. Now, mind you, this is a very, very common problem. And please note that there are several educational seminars that I've created on our website, which are accessible to everybody and anybody who can watch it. And most of the detailed information are in those specific seminars. This is a bladder pain condition where a patient has urgency and frequency. Now, this is not a condition where she would leak urine, but if she does not go, it'll cause discomfort, pressure, pain, burning, and that's why she has to empty. And that's because of some problems with the pelvic nerves. It's often misunderstood as endometriosis, pelvic pain, whatever other bladder infections, and you got to be careful about that. And that's the bladder pain condition, which was previously called interstitial cystitis. Now, the other bladder conditions we take care of are bladder infections, which are very, very common and should be properly diagnosed and properly treated. You must watch the seminar that I've created on this. It's very important to know this correctly. Blood in the urine, which is also important and should not be missed. Incomplete bladder emptying, such as retention conditions, also are important to take care of. From the vagina, we have the prolapse of the vaginal bulge, like something is falling out. This is the vaginal bulge coming down. And menopausal conditions, where this is the normal vagina, and here you can see it's intense lack of elasticity after the menopause, and the vagina is almost shutting down. The bowel conditions are accidental bowel leakage. So this is the normal sphincter, and the sphincter is weak, then there is bowel leakage that happens. Or it could be intense constipation, where the stools are just not coming down, whether it's a bowel problem or a muscle problem, and that's something we'd figure out. Very rarely, we may also see, just like the uterus coming out, we may see the rectum prolapsing out and cause rectal prolapse and stool leakage. You know, when you look at all these conditions, 1 in 2 women suffer from at least one of these conditions. 1 in 2. And I don't know, maybe that's just the tip of the iceberg. Maybe there may be many more women who have it, much more than that. You know, the sad part is that women wait at least 3 to 5 years after this becomes bothersome before they come for treatment. They wear pads because they believe that there is no option. This is what it is. This is just like aging. This is what's going to happen. And it is considered a normal part of aging. And that's so wrong. They should never be waiting. They should never be wearing pads. And it is not a normal part of aging, a natural process of aging. So first thing that we do when you come to the office, or before that, when you've gone on our website, we do what is called a history. And we do a very, very comprehensive history assessment. And yep, one of my patients said, "Man, what have you given me? Am I writing a storybook or an encyclopedia? What is all that?" All that? Yep, it's all that, but I'll tell you why all that. So first is a urinary questionnaire that we give our patients who have urine leakage that goes over how many pads you're wearing, how often you go. Then it breaks up into the urgency part of the leakage and the coughing part of the leakage. Then we have a sexual function questionnaire, and to see how much the disease state, whether it's prolapse or leakage, is bothering your sexual function. And this looks at different domains, just pain during intercourse. Is intercourse bothered by urine or stool leakage or by a vaginal bulge? Then we have a third form called the pelvic floor distress inventory, and that basically has different domains. Again, it talks about the bulge and how much a bulge is bothersome. If you have bowel leakage, then how much is that bothersome? If you have urine leakage, then how much is that bothersome? Then we look at a quality of life. I mean, yes, these are the bother questionnaires, but now how much does it really impact a woman's quality of life? Like ability to do just regular household work, how much does things bother? Ability to not do normal activities, going to a movie and things like that. Then we have a special questionnaire for urgency and frequency questionnaire that looks at how frequently you're going to the bathroom. Do you have pain if you don't go? And if you have any urgency. Do you know? So you'll say, okay, why am I doing so many forms? Do you know 80% of patients who come to our practice do not know that we address all these different pelvic floor conditions? You know, they come for urine leakage and they do not know that we also address bowel leakage. Or they come for urgency and do not know that we can help them with menopausal changes and pain during intercourse. So we are a multidisciplinary practice in that we are not a urology or a urogynecology, and that's why it's called the female pelvic floor medicine. These questionnaires are very helpful because the validated questionnaires, they address several domains of healthcare and help uncover medical issues that may have been considered as a normal or natural part of aging, which is not. For example, a woman comes in for urine leakage and she is passing gas and she thinks, well, I can't help it. You know, this is it. I'm going to be farting left, right, and center. Well, no, we can help you with that. Or she has discomfort during intercourse and she has never known that this discomfort should never have been. She's always felt the discomfort ever since she engaged in intercourse. So she thinks this is normal. And then we show her that no, this is not normal. 50% of patients, now mind you, half of the women who come in to see us for one condition actually have another condition that's equally or more bothersome than the primary complaint that she came for. So she came in for urine leakage. Our questionnaires discovered that she also has bowel leakage from history forms. And when we asked them, so her goal is to, when she came in, she says, oh, help me with my urine. Now, when we uncovered this history, now she says that no, my bowel leakage is actually worse than my urine leakage. And if you had to fix just one thing, I would have you fix my bowel leakage. So you see, that is why it's very important to fill out the forms completely. And systematic questions that can be tested over time is also very helpful. Then one can assess and gauge the effects and the success of a treatment that has had on a patient's condition by comparing before and after questionnaires and seeing the change. And the FDA is now saying that, guys, it's not about what you think as doctors, what's called the objective assessment. It's what is the patient saying. So it's important to know what she's also talking about. And these questionnaires also assess what is the impact a condition has on the patient's quality of life. So for example, she has urinary incontinence that we may find on exam, but it has no impact. It doesn't bother her. Or it affects her life a lot. She cannot have intercourse. She's afraid of having intercourse because of leakage. She cannot go anywhere because she feels she smells like urine. So it completely disrupted her life entirely. Or for example, patient has a vaginal bulge as a finding on exam. A patient is seen by me because she was sent over because she has a vaginal bulge, but she's not really bothered by it. She just barely notices it, but she says, my gynecologist sent me to you because I have a bulge. Whereas someone has urine leakage only when she plays golf, like I told you, but it impacts her quality of life a lot. So that's the history. So it's very, very important that you fill out the history forms correctly. And at the end of this, I will show you where to go to our website to find the history forms. But it is really, really important to fill the forms out completely and correctly because it'll help us help you. Once we've reviewed the history with you, then we will go ahead and do the examination. See, this is the typical gynecologic examination, right? The woman is lying down. These are her feet into that footrests, and then we're doing the examination lying down. But you know what? That's really not a true exam. It's more because the fallacy here is that it's not how we normally live lying down. But this is the only convenient way that you can look at and do an exam properly for the surgeon or the doctor doing it. Then we have the patient sometimes bend the legs bent up so then we can actually see the pelvic floor as it tilts. And this is how I do the exam. So I have the patient holding the legs up and she's straining down and you can clearly see as the bulge is coming out there. But let me tell you, the most important way to do an examination is standing up. This is an age-old French slide that shows how a woman is being examined in the standing position to check especially for prolapse. Because remember, when we stand up and we strain, then gravity also is pushing down, and that is when we can examine the best as to what is really happening. And that's also what we do. So what I do is I prop my elbow on the stool, I'm down on my knees, and I have her stand up with one leg on the table, and then she's straining down, as with my headlight I can actually see inside and see what's going on. So this is whether she's leaking and she would leak out, or if she's coughing and the vagina, the bulge is coming out. This would really help us understand what happens in her regular activity life, which is when she's usually upright. Now there's another position that we would do is put them on like a toilet seat, especially if they have rectal prolapse or vaginal prolapse, and that becomes even obvious. For a rectal prolapse, this is one of the best ways to check it, and we do have a toilet seat that we'll put the patients on. You know, it's very interesting. The rectal prolapse will not come out if she is just being examined normally. But once you put her on that toilet seat, it automatically, as she starts straining down to have a bowel movement, you can actually see it coming out. Self-examination is now the key. You know, once you have understood through the videos that I've put in and the educational seminars, the different conditions, you can examine it yourself. You know, here after urination, you know, you're wiping yourself and see, what is that? What is coming out? So you say, okay, let me see what that is. So then you look in with the mirror and say, okay, this is what's coming out and this was not what's coming out. I would encourage everyone to just do a simple examination of yourself to see what normal anatomy looks like, as you can compare to the educational seminars that I've done. And once you know what your normal anatomy looks like, then you can know what your abnormal anatomy would look like if it were to happen. So you'll say, why the different positions? So lying down, I told you, is just for our convenience. Legs bent up is somewhat helpful because it rotates the pelvis. And when you rotate the pelvis, it helps because now the organs are coming straight outwards. But standing up is the most accurate as it simulates daily activities and events. And it is difficult and it's awkward. You know, it's difficult for the patient to stand up and it's difficult for me to go down on my knees. But you know what? If it has to be done correctly, that's what you need to do. So remember, gravity forces, standing is the best, better than sitting and better than lying down. Most pelvic floor conditions are impacted by gravity, and even in standing, the longer the patient is upright, the findings change. So the early morning may be different from late evening. So a patient may come in, she's doing all the right things, we are doing all the right things, we're having her stand up, she's straining down, but you know, it doesn't seem to be that obvious like what she's saying. Let's say she says, oh, it's a ping pong ball coming out of the vagina. That's how the size is. And I barely see it coming to the opening. And then I'm wondering, why does she say that? Well, that's because it's a wrong time of the day. She has just come to the office, just woken up. So it's not as bad as if she were on her feet for a long period of time. Same thing with urine leakage. Most women leak standing up and not lying down. You know, 40% of women in our practice do not leak lying down and coughing, but did so standing up and coughing at the same volume. So she's lying down, coughing, nothing. We have a stand up and boom, she leaks. The prolapse degree and type is more obvious standing up and straining. Even patient will say, I notice it more standing up, doc, so make me stand up. Don't keep me lying down. So sometimes you may realize that it's just the bladder, but the moment we have her stand up, we realize that, oh, it's also the uterus which is coming down. So yeah, you know, patients would say that, yeah, it's a little odd to be standing and, you know, being examined like that. So what would you have? Would you have it awkward and embarrassing, or would you want me to make a wrong diagnosis and wrong treatment? So remember, this is not really awkward and embarrassing. It's more about getting understanding what we'll be doing. And once you know that we'll be doing this way, you understand the value of why it is done, so that we do not want to do this. As I mentioned, if it's the first thing in the morning, you may not see the full extent of it. And that's why I tell my patients, today's day and age of smartphones, take a selfie. Take a picture of that vaginal prolapse or whatever is happening. There's a cyst there. Take a picture and you can email it to us in a secure manner, or you can bring it with you. Or especially if there is, we can even go live, someone saying, I'm really bleeding and we need to figure out where is this blood coming from, then that could be done. Or if there is a bruising after surgery and she said, I feel very bruised, I can say, all right, why don't you show me exactly what you're talking about? And there we can communicate. This is going to be the future anyway. Once 5G comes in, I'm telling you, medical healthcare is going to be completely revolutionized. The visits at the doctor's office are going to start decreasing. A lot is going to be done through the media, and that's going to become more and more secure. The power of this is eliminates guesswork, especially with self-exam, helps the doctor assess the problem remotely, and improves the likelihood of correct diagnosis and treatment. So that is how we do our examination. Now let's switch gears and tell you a little bit about why we track our patients. So once you're part of the practice, you are done. You are with us now. Unless we tell you okay, or you are very happy and you say bye-bye, you are with us for the long haul, and we will make sure that your health care is taken care of. The reason why we do that is because of this very reason. Remember I told you that 65 to 75% with bothersome leakage do not return. If the doctor or that specialist had just called the patient and said, Miss Smith, you never came back. What happened? This number would be dropped down significantly. There is no follow through. Most of us are so busy, we do not track our patients, and that's a problem. So for us, it's important because we publish, we want to know what we are doing. We want to know how we are doing things to answer this question. Doctor, what is your success with this procedure? Doctor, what will be the risks that you have seen with this procedure? And doctor, how long will the success last? So for me to answer these questions, I need to have evidence. So show me the evidence, not show me the money. Show me the evidence. Now that's what should be coming out of his mouth, or at least your mouth. So when you go to a doctor's office, you should say, doctor, show me the evidence. Where have you stated your results? And we will be more than happy to show you that in our practice. So we want to make sure that the patients complete their treatment, understand also why she stopped taking the medication, what happened, and to follow the patients to assess their improvement and tweak things along to improve their success and patient satisfaction. Sometimes it's just lack of communication. Sometimes things have changed and we need to adapt. Insurance has changed, she can't afford it, we need to change things. She goes on a different medication, maybe for a heart disease, she's taking a fluid pill now, we need to adjust. So all that can only happen if we follow our patients. We also want to provide our patients with evidence-based information about our experience and success based upon patient follow-ups. So then we can tell you that, hey, we saw these patients and we saw them right through. And remember I started saying that's exactly what the FDA is saying. Subjective. What does the patient think rather than what does the doctor think? Remember, in our tracking philosophy, it's very much like clinical research philosophy. For most doctors' offices, it may be no news means, hey, you don't hear from us, everything is good. We totally disagree with that. No news, if anything, is no news. But in our book, no news could very well mean bad news. And that is why we want to empower our patients. Just like, this, if you know this fearless girl statue at Wall Street, facing the bull of Wall Street, that's what we want women to do. We want to provide you with the correct information, the correct data, the correct stuff that you can now take care of. And therefore, you can make your decision yourself based upon the information, and we will guide you along. We will never let you hang out there. We will follow you, make sure that we are aware what is happening and you are satisfied with your treatment. So I'm actually going to show you how to navigate now the patient forms on our website. So now that we've gone over all that information, let me show you how to get to the history and how to navigate our website. So if you open the browser or any browser, you go to augm.org, and that is our website. So remember, it's augm.org. So when you come to the first page, you go to patients. Under patients, when you go to patient forms, you click on that. And now you can see the new patient packet. So you click on that, and now this is it. So here you have the whole thing. You have our entire policy. You have our, remember, these are two-sided forms. So please fill out both the sides. This is basic history, going over your obstetric history, then your medication. Now this is really important. Please make sure that you fill your medication list completely, the name of the medication, the dosage, how often you take it, and how is it given. And then anything else that you take over the counter, such as, baby aspirin or CoQ10 or whatever you may be taking. And please state your allergies to medications and also what surgeries you've had. Then these are the forms that I went over. This is the urinary leakage form. Then this is the quality of life form. This is the pelvic urgency and frequency form. If you're not, this is the sexual activity form. If you're not sexually active, just state that I'm not sexually active and you're done with this part. Then, and again, if you're not sexually active because of the prolapse, then please state why you're not sexually active. Just fill out this part and you're done with that. You don't have to fill this second part if you're not sexually active. And this is the other form I talked about. Talks about the urine, the bladder, the bowel. And then this is really important. I want you to state what are your goals that you want us to achieve. So anything that you want to put up here, any additional information. And finally, please remember that if you have any surgical records, you should bring it with you. It's really important for me to see what has been done in the past so I can better assess your diagnosis and your management. So please make sure that you fill out these forms properly and completely, and that'll help us a lot in instituting a smooth and a quick and a swift treatment.